and welcome to the operating room of Duke Spine Institute, located here in Orlando, Florida. It is April 11th, 2023. We are live streaming. Our next patient actually is from Arkansas, and he has had a fusion in the past, not done by us, at L4-L5. You're going to see that in a moment. Arius, when I say the word shot, it means take an x-ray picture. That's when you would flip over from the eye in the sky in the operating room over to the x-ray view. Okay?
Yep, it's going to be a big.
And I'm going to show you that this patient has had a fusion done at L4-L5. Now he's having adjacent segment disease at L4-5, L5-S1. He also has thoracic facet pain on the right side.
Traumatic injury to the disc can cause annular tears to form.
Facet joints during the surgery as well. So he has disc herniations at L4-5 on the right, degenerative disc disease, L5-S1 on the right, radiculopathy, back pain. And the back pain is coming from his facet joints as well as his disc. So we're going to treat both. He's also had a stimulator put in and taken out. It did not work. That's a spinal cord stimulator. All right, we're going to get started here. Right side, everybody agree? So first thing we're going to do is do the Duke laser disc repair. I think I'm a little low shot. Yeah, too low. Put that back. I need to be a little bit higher. Blood pressure is good. All right, let's see where we are here. Shot. That's a little better. Okay, so I'm going to be talking to my team throughout the surgery. But you can see the spinal needle. When I say shot, guys, that means go to the x-ray view for about 5 seconds and then come back to the eye in the sky. I need some num-num. You can feel the iliac crest there, which is a bone that is going to be near where we're operating. Shot. All right. So Jordan, see the double, there's a little double shadow on the pedicle. At 5, just slight. I think it's a slight wag issue. Shot. It's not terrible. That's probably good. I don't know if it's on the bottom of the pedicle we're seeing it. Maybe you gotta, you see what I'm talking about? The bottom of the L5 pedicle. Is that a double shadow or am I just imagining that?
I think it's double.
Yeah, so I think we need to wag it. Maybe the opposite direction. Let's try that. So that's better. It's very important that you, as the surgeon, start your surgery with reliable navigational information. What does that mean? It means you've got to know where the target is, and you've got to know the structures around the target. And to have reliable navigational information using an x-ray machine is extremely important. Spine surgery is done using reference points, and those reference points are going to be from the spine. The best reference point device is an intraoperative x-ray machine called a fluoroscope, which is what we're using here at Duke Spine. All right, so I'm sneaking in. You can see the trajectory of the needle, show them on the x-ray machine. Take a shot and take a look. You guys see the needle there? We're heading for the L5-S1 disc. Let's get an AP view. I don't know who's there, Arias or Jose.
Jose.
All right, are you able to see the x-ray view?
Yes.
Perfect. So when I say shot, go to the x-ray view and then come back after 5 seconds.
Okay.
All right, perfect. There's the AP view. Show us the cage that was put into his L4-L5 disc. Jordan, we're going to show you the cage. Take a look, Jose, go to the x-ray. You can see the screws and rods, and you can see the cage. Show the cage right there, yeah. You see that, Jose? The white arrow moving?
Yes.
All right. So that's at L3-4. Now he's developed pain below the fusion at L4-5, L5-S1. And that's why we're heading to L4-5-5-1 to fix it. He also has facet pain higher up, which I'll show you and talk about later. Is he reliable? All right, so I'm going to wait here at this level. I'm going to make an incision, and I'm going to go ahead and put the needle in at 4-5, which will be the next disc up. We use a 11 blade. I make a 7mm incision. The whole surgery is going to be done with a 7mm tube. It's called arthroscopic spine surgery, or endoscopic spine surgery is the other name for it. But it's very different than the open surgeries that people get these days. This patient traveled here because he didn't want another fusion. He didn't want a laminectomy. He wanted the more advanced treatment that we offer here at Duke Spine, which is the endoscopic surgery. Shot. All right, I'm heading to the 4-5 disc now. Shot. I can feel the pedicle. I'm a little higher than I want to be at 4-5, so I'm going to aim a little south. Shot. You can see the trajectory there of the needle heading right towards the foramen. Is he hiccuping? Shot.
I think he's just a little sensitive there. How you doing, my friend? You okay? All right, just stay still. Okay?
We're almost done. We're going to have you to sleep
I'm
soon.
gonna ask you a couple questions, so just stay with us, okay?
So I'm passing the facet. You could see the tip of the needle at 4-5 is the superior facet. Now I'm at the disc. You guys see that? Show us the needle there, Jordan. All right, so at L4-5, the tip of the needle is literally touching the herniation. See that? See the white arrow there, Jose? Show us the
Yes.
herniation. You can make out the herniation there at L4-5. Show us the needle at 5-1. Yes. All right, so I'm happy with 4-5. Is he okay?
Yeah. He's doing great.
So 4-5, I feel good. I've just advanced the needle into the disc space. Shot. Okay. 5-1, I need to finish advancing my needle. I just want to make sure the patient's awake and reliable. Any pain?
How you doing? You having any pain, sir? He said no.
This is the hardest one to fix, 5-1. You can see the needle is there at 5-1. I'm slipping into what's called Cambin's triangle, which is the space that is below the exiting nerve root. And it's at the back of the disc on the side. Shot. All right. So you can see we're right at the back of the disc at 5-1. And he's so collapsed here that I cannot get the needle in with him awake. I'm going to have to wait until he's asleep. So we're going to get back to this level later when he's asleep, and I might be able to get in at that time, but I cannot get in right now because the disc is so collapsed. Shot. So I'm going to get in a little bit later on when he relaxes his muscles. Hold on. Just try one more time. It's like we're right there. Problem is you can actually bend the needle if you push too hard, so you have to be really careful. I like to try my core drilling technique where I use the bevel tip of the needle to actually drill in through the bone spur to get into the disc space. And let's see, we call it the dancing needle technique, and it's just not working for us today. But we'll get in there. We'll get in there eventually. Huh?
Looks like you're heading in.
Yeah, we're right there. We're right there. You can see how the end plates come together at the back of the disc because it's so collapsed, so degenerated. But we'll get in. I'm not worried. All right, so I'm going to need him awake. Now, this patient,
I'm gonna ask you a question.
he has a scar right here on his back, you can see, from his prior fusion. That was done at L3-4. And now he's having pain just below that. And that is your L4-5. And he has an L5-S1 that's pretty collapsed, which we're not going to be able to test. All right, let me know if he's awake and reliable.
He is awake and reliable.
I just want to show you the other problem he's having is pain in this area which is his facet joints and the thoracic spine. And we're going to fix that later. He also has lumbar facet joint pain here and here at L4-5, L5-S1 below his fusion. We're going to fix that as well. All right. Is he reliable?
How are you doing, my friend?
You comfy?
Yes, he's okay. He's okay.
All right. How bad is that on a scale of 1 to 10, Shot?
Give us a number. 10.
10.
10, definitely.
All right, great. We're going to put him to sleep. So is that where you typically get back pain? Perfect. So he's lay still, don't move. Lay still.
We're giving you some
All
good
right.
medicine right
Show us the tear. Let's get a shot. Show us the tear in the back of the disc. Jose, go to the x-ray picture. Show us the tear. You guys see this black thing there? That is the annular tear. That's where all of his back pain's coming from. I'm going to go in there endoscopically with a laser and clean that tear out. It's called a debridement. When I do that, that takes his back pain away. We're the only center in the world that does this. Duke laser disc repair, annular debridement, Shot. That's why people travel from all over the world to get here. Okay. Any questions from our audience, Jose?
Stay still, my friend.
No question
Doing
at this
great.
time.
Stay still.
All right, Jose, can you show us the video? Yeah, you're doing fine. The educational video, Shot, that shows why does a herniated disc in the lumbar spine, lower back, why does it cause back pain? Meanwhile, I'm going to bring my dilator over the guide wire into the annular tear and disc space so we can start this Duke laser disc.
Traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Duke laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Duke laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear.
And I've just placed the tube, the endoscopic tube, into the L4-5 disc space. Shot. And you can see the tube. Show us the tube, Jordan, inside the disc. specifically, we are inside the tear called the annular tear in the back of the disc. There's the tube, there's the tear. And what we're going to do is we're going to now use the endoscope to debride the annular tear and remove the inflammatory tissue that's causing all of his back pain. That inflammatory tissue is located in the back of the disc. Fluid adapter. All right. Can you see this, Jose?
Yes.
This is the scope for those of you who have never seen it. This part is the scope. It's a rod lens scope. Here's the irrigation. Here's the light source. Here's our high definition camera. And there's a working channel that I do all my surgery through. It took me about 100 surgeries to get really comfortable with this treatment. That happened obviously around 14, 15 years ago. Now we're in the thousands of treatments. Duke laser disc repair has been done over 1,600 times in 1,600 patients. So the success rate is 98% on average of back pain from the discs, called discogenic back pain, eliminated with this surgery. Of course, it only eliminates the back pain from the disc that we're treating. Great job, guys. You're welcome to keep him as light as you need to, doctor. He doesn't seem to be, having that much discomfort to me. So whatever you're comfortable with. Any questions?
No question at this time.
All right. So unlike the cervical, the laser fiber for the lumbar we use is a 1 millimeter fiber, right, Luis?
Yes, sir.
Whereas the cervical is a 0.5 millimeter. We used to use the 0.5 millimeter on lumbar a long time ago, but what we found was that it caused the surgeries to take a lot longer. And when you're dealing with anesthesia, the shorter the surgery, the better for the patient. Why is it so red? You got to turn the red targeting down. It should barely be red at all. This is a blue company, not a red company. I don't mind if it's all the way up, it's fine. I don't really need the targeting. But you can have it right where it is, it's fine. It looks like it's on still, and it's fine. All right, you can see the tear here, the annular tear. This is where all of the patient's pain is coming from. We're going to clean up this tear with the laser, and specifically we're removing granulation tissue, inflammatory tissue, blood vessels, little nerve fibers that are there that shouldn't be there, and we're removing the blue stuff, which is the herniated nucleus pulposus stuck inside the annular tear. It's called the interposed herniation or interposed nuclear material. And we're removing scar tissue. Still a little blurry there, that's better. So Luis, see if you can procure more scopes.
Lumbars?
Yeah.
Yeah.
And, huh?
They are AC.
Good. Get some good ones.
Okay, no worries.
And if you can, the other one, the cervical as well. Always look.
Yes, sir.
I don't know that I can find another source. How's our patient doing, doctor?
Doing very well.
Good. So just to reiterate, Duke Spine is a medical tourism center. We have patients that come from all over the world for these surgeries. And today we have patients from England, Washington State, Arkansas, and Texas. Our last patient will be from Texas. This patient is from Arkansas. The one before was from England. She's doing very well, by the way. I checked on her before I came back here. She'll be ready to go soon. All right, there's the top of the tear. And you can see the annular fibers coming together right there. There's still herniation here. So far the surgery is going well for the patient. When you're doing these, you have to make sure you don't just get the medial herniation, you got to get the lateral herniation too. A lot of these, because we're approaching the annular tear and herniation from a lateral approach, and you're approaching it and you're coming into the disc tear, into the spinal disc, really in the paracentral region, in the foraminal part of the disc. You want to aim medially so you can get the paramedian, paracentral region, and you want to look lateral so you can get the foraminal, extraforaminal parts of the herniation. That's a piece of herniation that just flew by. All right. Still a little bit more of the tear. The blue stuff is herniated nucleus pulposus. Not just herniated, but degenerated, but not too degenerated. The reason it's blue is it's staining with the dye that we put in. And the dye that we put in will bind to acidic, spelled ACIDIC, acidic, which means it has a pH less than 7.4, acidic nuclear material. Remember, the nucleus pulposus is composed of hyaluronic acid and basically what are called proteoglycans, which are combinations of amino acid proteins, short chain or single amino acids, and sugars, which are your glycans. So the nuclear material has these very hygroscopic, which means they bind water, molecules. And the nucleus pulposus comes from the embryological structure called the notochord. The notochord is very important in the formation of the adult tissues, especially the spinal tissues and the nervous system. Then the notochord becomes the nucleus pulposus in the adult and the child. Just about done. I was talking to this patient earlier about where he's from in Arkansas, and he's from Little Rock along with his wife. And one of my colleagues from medical school at USC, she became an orthopedic surgeon. She practiced in Arkansas and Little Rock. Elizabeth Siegler. So I was asking if he knew her. Turns out he does not, but I don't know that she has the same last name because she may have gotten married. But that was her maiden name, Siegler. Anyway, she and I were roommates, or apartment mates, I should say, condo mates at USC in Los Angeles when I was there. And also very good friends. But like many good friends, you fall out of touch with them over the years. She, I'm sure, got married, and so did I. All right, just about done. Another minute or two and we'll be finished. This is that tear. We're doing an annular debridement. debriding the annular tear, removing materials out of here that shouldn't be here.
I'm gonna take a little picture of this.
That's up to you, yeah, that'd be fine. A lot of scar tissue from chronic inflammation. Remember, this is the adjacent segment to his prior fusion. So this is the disc just next to his fusion. His fusion was at L3-4. This is the L4-5 disc. I expect, and I told him, I expect about 95%, 99% of his pain to be gone after the surgery. So he was able to show me before surgery exactly where the pain was. So it takes a very good patient communicator. You got to be able to communicate to your doctor exactly where you're feeling your pain. And the problem is most doctors cannot figure out what structures those are. But at Duke Spine, we specialize in diagnosing the source of back pain. All right, just about done. I'm going to take a look here to the side in a minute. I'm going to show you the nerve root. The nerve root I'm going to show you is going to be the L4 nerve root on his right side. You can see just how close we are to the nerve roots. That's why the patient has to be awake in the beginning. As we pass by the nerve root, we don't want to get too close. So that's why the patient's awake. They will tell us if we're too close to their nerve root. All right, so the nerve root's going to be right here, but there's a lot of fat covering it. You don't really get to see it, which is not a bad thing to not see it. It means it's protected, but it's right in that fat there. And that's where the herniation was. So we're done with that. And we're going to move on to the L5-S1 disc. And then after that, we're going to move on to his facets. A little bit of antiseptic. Remember, the whole surgery is being done with a 7mm incision. It's a very small incision. There's no bleeding. There's no scar tissue. There's no damage to any part of his body inside except for the disc, which is already damaged. We're not doing damage, we're actually repairing the damage. So the beauty of the Duke laser disc repair endoscopic procedures is we don't create damage to normal structures. Every other spine surgery out there, artificial disc, laminectomy, microdiscectomy, fusions, foraminotomy, you name it, it causes damage to your body. Their surgeon is really actually hurting your body. Many times they're hurting your body more than they're helping your body. All right, we're going to bring the fluoroscope back in. Remember, our patient is now asleep, so he's more relaxed. I'm going to try to access the L5-S1 disc. Now, we've been in this situation before where the disc is quite collapsed down and there's not much space in the disc, so trying to get into the disc through the back is very hard, even with a 1mm needle. But when the patient's asleep, they're relaxed, they're not tightening down, they're not contracting the paraspinal muscles. It's easier to get into the disc. That's what I'm going to try now. Thanks, you're fine. Shot? All right, so there it is. Beautiful. We've already fixed the L4-5. Now we're going to go for the L5-S1. All right, so still struggling to get into the space. I'm going to bring down my guide wire. I just feel a lot of bone spur right there. So I'm going to bring my guide wire down, and I'm going to now bring my dilator over the guide wire. Shot? That's it? Uh-huh. Good. I'm going to leave the dilator there. The guide wire there. And I'm going to remove the needle. Shot? Yep. So you can see the guide wire is still there. By the way, this is the new X-ray machine we talked about, the fluoro machine. This is the top of the line, made by Siemens. It's the best in the world. Shot? And what is it called? Flow? Yeah. Yeah, it's called a flow, a Seaman flow. It's quite literally a $170,000 machine, and we bought 2 of them, so they gave us a little discount. And we are a big believer in top technology at Duke Spine. We want our patients to have the very best treatment. You can't have the best treatment without the best equipment. Okay, it's just that simple. And there's certain types of equipment that you need to do the surgery at the very best level that could be done. And the fluoroscope is one of those pieces of equipment that are extremely important. So we don't compromise on quality. It's kind of like, imagine if you're doing a wedding cake for somebody. Shot? You can go cheap with some cheap ingredients, or you can make sure that you spend a little extra. All right, let's take the guide wire out, and you get the best ingredients for them. Go ahead. Wait. All right. Shot? Uh-huh. Looks good. All right. What happened to the end of that thing? A little curly? Shot? So it's going to be tough getting into 5-1. You start to see the separation. Yep. Shot? Yep. We're in. Very degenerated disc, okay? Very degenerated disc. So people ask me, Dr. Duke, I know you can fix disc herniations, but what about bulging discs? Yes, bulging discs are herniations. What about degenerated disc? Yes, we can. Because degenerated disc, everyone thinks it's the bone on bone that's the problem. It's not. It's actually the annular tear. And it's always the annular tear. It doesn't matter if it's a bulging disc, a herniated disc, a ruptured disc. Let's do some, I was going to say some irrigation to prevent a cold weld, but it's too late for that, huh? So, it's all right. I like your positive attitude. It's beautiful. Oh, it's happened. You see the dilator moving? All right, let's go ahead and take it out. So the dilator is migrating forward with the tube, meaning that there's a cold weld, which is meaning there's a piece of disc material stuck between the dilator and the tube. And that does happen quite often. And then when we try to take the dilator out, sometimes the tube will want to come out too. Is that happening? Huh? We're okay? Oh, nice job, Luis. Oh, no, it's all you, my friend. Yep, teamwork makes the dream work. So we're good. We've got the tube in to L5-S1. Like I told you, if you struggle when the patient's awake, put him to sleep, let him, do the easier disc then, and come back, and you'll get the harder disc done when the patient's more relaxed. Just think about it. If the patient's feeling pain, all the muscles here in their back tighten up, and they clamp down on the bones. So the disc space gets smaller. It's harder to get into. But once they're asleep for a while, it's easier to get in. It's a little trick from the Duke Spine Institute for you endoscopic surgeons. There's a lot of endoscopic surgery going on in India and China and even Korea now, but it's not good endoscopic surgery in my opinion. It's better than some other stuff, but it's done with what's called the UBE, where they're going unilateral biportal endoscopic surgery. It's far more invasive. They don't go transforaminal a lot of times at 5-1. They go translaminar, which means they're removing the lamina and ligaments. They're destabilizing your spine. You don't want that done. All right, you can see all the red. The red is, look at the inflammatory tissue. That's the end plate of S1, the superior end plate of S1. Look at how grungy it looks. It's been inflammatized. We got to come up with a word. Nobody's ever had this word. Dr. Berndes? Inflammated. Oh, I like
How
that.
about inflamed?
No, it's boring. Inflamed. But inflamed doesn't mean chronicity like structural changes. I want something that implies structural changes related to the inflammation going on for a long time. So you can't just say inflamed.
Decimated.
No, it has to be like inflammated or something. Not just inflamed, inflammated. What is it? There's no such thing as inflammated, right? So we can use that word. We can make things up.
We're going to the thesaurus right now.
Inflammated. It's kind of like decimated, but it's from inflammation. Decimated from inflammation. Inflammated.
Decimated is from decimation.
No. Decimated is a state of being. It doesn't tell you how it became decimated. But this is decimation from inflammation. So it's inflammated. I like that. Let's create a new word. Why not? I mean, people create new words all the time for lesser reasons, right? My kids, they're teenagers. They're constantly saying things that I'm like, what the heck does that mean?
They have their own language nowadays.
Huh?
These kids have their own language nowadays.
They have their own language. I mean, you remember high school when people used to speak in Pig Latin, right? I never could learn Pig Latin. My sister and her friends would always speak in Pig Latin. These new words that,
I was too busy studying French and Spanish.
I know, I was trying to keep my head above the water with French. Man, I don't know, my dad spoke 7 languages fluently, but I have a hard time speaking.
Thank you.
I have a hard time speaking just an extra language, you know, like French. Holy mackerel. French was the hardest subject for me in high school. I really struggled. I spent more time studying French than I did every other subject put together. And I did the worst in French. I got a B. Like a B plus. That was my only B in entire high school, was in French.
My only B in high school was in Mandarin.
Really? Chinese. You guys had Chinese available? That's amazing. No, we didn't have that. We just had boring languages like French. My sister never studied French. Never. And she never got an A in any other class except for French. The only class I couldn't get a damn A in. I would go crazy trying to get an A in French. You have no idea how much time I spent. It just, language just doesn't, it's not logical to me. All right, laser on. There are people that have that language brain and people like me who don't. And I'm like, my language brain is equal to my singing brain. I have no ability to sing. I have no ability to learn languages. These Google Translate was the best thing that ever happened, you know, to me, from a language standpoint. All right, we're almost done with 5.1. Are there any questions? Just make sure they're not in French.
No question at this time.
No questions. Why do we have no questions? What are we doing wrong? I think that we're may not be streaming. But then I saw the video and it's there. Are you sure we're streaming?
Yes,
Did you
we are.
verify it on the laptop?
Yes, we are.
Somebody ask a question just so we know that you all can ask questions. The reason why we're saying this is because Henry, who normally does our broadcast, is out. He was here this morning, but he's out. And the rest of us are not 100% on this system. That's a bone spur, by the way, if you're wondering. Yeah, he's not liking that. Sorry for the redness too, by the way. That's nothing I can do about that. The reason why there's more red is there's a little bit more bleeding, and the bleeding is coming from the arthritis, the what do we call it? Inflamed surfaces. Huh?
Yeah,
Right? Yeah, it's bone on bone. All right, let me see the laser. Hold on. Let me see. Yeah. So the nice thing about the collapsed discs to me is they're very quick to fix. They don't take too much time because, well, there's frankly not a lot to do. But at the same time, they're a little bit more challenging because they're so much red. Should be done in about 2 minutes, doctor. Yeah, he's definitely not liking this.
Did you get a chance to put any local at the DPR sites, is that correct?
Nope. I need a little bit of help. He's tightening up on me. Let's see the grabber. See that? I kind of shoved it in, right? And then I can get it with a laser a little better. Laser. This is all from, none of this is normal. None of this stuff here is normal. It's not found here normally. This is all very abnormal. It's only here because of the chronic inflammation caused by the herniation. Let's see the grabber again. How many of the grabbers do we have, Luis? We have enough?
Yeah.
Hold on. I'm going to come back a little bit more there. All right, laser. All right, you said 4 or 7. Which one? No, we need more. We need more than 4. Did some of them break? Is that why? Some of them broke?
There's one out, yeah.
Out is in
Out is in the solo is
broken.
broken.
All right. Luis, we need more. We need to have about 8 of them. So please order more. 8 to 10. All right, that was good. So I've gotten the bone spurs out, just left with some soft tissue here, scar tissue basically. That's inside the disc. That's not causing any problems. You see that white stuff? I'll clean a little bit as much as I can, but the rest I'm gonna have to leave. That's not causing any symptoms. I'm not worried about that. I don't see any herniation. I got another minute and I'm done. Then we're gonna move on to the plasma rhizotomy. Let's see the grabber again. Yep. That's it.
Lights off, please.
Yeah. His nerve root's right there. You guys see the nerve root right there? So there's less fat on that one. The yellow stuff is the fat. And the little red bleeders are veins on top of the nerve root. But that's the nerve root. You can see we're just below it. That's how tight it is in this foramen because he's got no disc left, basically. He's collapsed his disc. I'm going to do a little antiseptic, but it's okay because we got the pressure off the nerve root.
No, it's good.
Any questions?
No question at this time.
And you're sure? I mean, you're sure people can ask questions. Why don't you try asking a
Yes.
question? Why don't you do the on the laptop, ask a question, and see if it pops up? Because normally our audiences are always they're asking like 10, 15 questions of surgery. Sorry. All right. We're going to move from the endoscopic disc procedures to the plasma rhizotomy. Next, I'm going to take this tube out. Let's bring the fluoro in. So this is going to be a very heavy fluoro-based procedure. Jose, we're going to do a lot of fluoro shots, almost exclusively fluoro.
White one, the 20cc white one.
So plan on keeping it on the fluoroscope for a lot. Let me know when you're about ready.
All these can go,
Ready?
all the numbers.
Who's ready, Jordan or also Jose?
Jose.
All right, shot. All right, perfect. So let's see the transverse process junction at L4 pedicle. So you see where my marker is? Shot? I need to see that one right there. Take a shot. Yeah, right there. So you're going to have to rotate around that. You're going to have to rotate around it. Because the screws are in the way, we're going to have to come from the side with the fluoro. Shot? That's going to be your side, right? I want to see my side first. A little more. Just a little bit. That should be good. All right, that should be good. Can you see the TP? It's kind of hard to see the TP, huh? I think it's a short TP. The other sides are generous. All right. Anyway, I'm going to go ahead and place. Can you get the fluoro away from the patient, so raise it? Uh-huh. Yeah, that's good. Give me a second. Shot. All right, I need to see more of my side. I think you're okay on the fluoro picture. I would just leave it for now while I do the first rhizotomy.
Put local in.
Shot? No. Uh-huh. So the needle's disappeared. You see that? It's hidden by the hardware. Shot? Wow, interesting. I'll try a little bit more of a lateral approach. Shot? That's better. Shot? Can you see the TP there? I can see the TP at 2. It's very faint. Is that the top? I don't think that's top. That's the bottom, right? Shot. If you could make it a little bit darker. Shot. I feel the bone right there. I think that's as good as we're going to get for the top. Hold on. I mean, I feel TP right there. I feel TP at the tip. Yeah. That feels good. Let me get the skin knife. We're going to make an incision. Yeah. Thank you. Coker. Shot. All right. Not bad. So the problem here is this, obviously with all the scar tissue from the prior surgery, makes it difficult, but we're going to get it a little bit too superior. That's a little better there, shot. And before I push it down into position, I want to make sure that I'm over the area I need to be. Shot. I can kind of see the top edge of the TP. There we go. All right. Shot. Too low. Shot. Shot. Hold on. Shot. That's better. I'm right where the TP is. Gotta find the right spot. Shot. Too lateral. Let's see, shot. That looks pretty damn good. Hold on. I'm just not on the bone, that's the problem. Shot. No, way too south. Just a little adjustment. Shot. Too south. Shot. That looks much better, but I'm not feeling the bone. Shot. You can see the pedicle. The TP would be coming right off there at the pedicle. I mean, we're supposed to be in a perfect spot for it. I'm just not feeling. Oh, there's some bone there. Shot. Could that be it? No. That's too low. Shot. I feel like that's too lateral. Shot. 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 Damn it. I'm wondering if the surgeon didn't take off his TP. The prior surgeon. Shot. I'm on top of the screw. I'm going to slide down the screw. There's like no TP here. what the hell that surgeon did. Maybe that's why we're not seeing the damn TP. Because it's not there anymore. Jesus. I'm just going to have to burn lateral to the screw. Shot. That's the perfect position. If there was a TP there. Let's see. Not bad. So much bone graft here from the fusion. All right, that should be it. Fuck. All right, let's get lined up for the next one down, L5. Should be a little easier to do. All right, that looks better. You can see the TP, you can see the pedicle. This should be a little bit easier for us, hopefully. Don't want to jinx myself, shot. It's too lateral. Shot. It's a little better. Shot. That feels good. Shot. That looks good, right? You agree, Jordan?
Yes, sir.
It's right on the TP.
Right.
Yep. So our next spot that we're going to be rhizotomizing or burning is the L5 pedicle transverse process. And blood pressure is good?
Yes. Yes. 108.
Huh?
108.
Shot? It's looking nice. If I can get a little more medial, it'd be better. Shot? That looks pretty good. I can go a little more medial. I feel the superior facet right there. So I think that's as good as I'm going to get it. Let's just see where this is. Hold on. Shot. It's too lateral. But it's forcing me lateral. Shot. Cannot go more medial. Shot. That I'm on the facet itself. Facet is enlarged. Shot. Shot. Man, talk about abnormal anatomy. That feels solid right there. Shot. That's right on the TP. All right, I'm going to go ahead and get that spot because I think the nerve is going to be right in this area here. That should do it. Let's see where this is. Shot. Shot. That's really medial. All right, that should do it. I burned in that area where the nerve would be. This is not the nerve root, by the way. We're burning in the area of something called the medial branch of the dorsal ramus. There's a nerve that innervates the facet joint. It's called the medial branch of the dorsal ramus. And when doctors try to denervate the facet joints for facet joint pain, I have to do S1. Stay here, Jordan. They end up shot. Oh, look at that, right on target. I just have to get to the bone. Shot. 2 south. I was on target. Shot. It's close. I could be a little more superior. Shot. That's a perfect spot. Go ahead. Hold up. All right, let's see if we can find that spot again. Shot. A little too high. Superior. Shot. Not bad, but could be a little more. Shot. Oh, that's nice. If we can get that. That's a nice spot right there. How's he doing?
Doing well. Blood pressure's good.
Just want to make sure I'm on the bone. It's like the perfect place to be right there. If I can, but I just feel so much scar tissue from inflammation. I'm trying to get down to the junction of the sacrum and that superior facet of S1. Jordan, show the audience where the nerve runs. Shot. It literally runs right where the tip is, so that's the pain nerve to the facet joint. And that's what we're trying to get with the Bovie. That's what we do. We use an electrocautery device. It's a standard surgical tool. We use it all the time in spine surgery. I think I got it. And we're using it because it's more powerful than a radiofrequency ablation probe. Therefore, it has a higher chance of successfully treating the problem. All right, we're going to start back up at the, I could see the transverse process better at 4 on your side, whereas I couldn't see it that well on my side, but I could see it better on your side. Shot. All right, definitely going to have to be more lateral. That's better. Let's find the target. Shot. I feel either metal or bone. Come more to your side or rotate more. I need to see a little bit more. Just the tiniest bit. Well, I see the target. Is that the tip of my needle right there? It looks like it, right? Because I'm right on target. Yeah. It feels like transverse process. That's the good news. Coker? Shot. All right, it's not bad. Need to be a little more medial. It's the fascia that's keeping me from getting there. Looks pretty good there. If I could just get, there's the bone, I actually feel it. Let's see. Shot. That's kind of where we want to be, slightly more medial. Shot. It's right where the TP is meeting with the superior, with the pedicle, superior facet. Jordan, you agree?
Yeah. Looks like it's right there.
That should do it on that side, at that level. 2 more to go. And by the way, we're having to really turn the fluoro quite a bit, rotate it, we call it, in orbit, because of the screws and rods from the prior surgery have made it really difficult for us to see the pedicle and target it in the transverse process. Yeah, it's fine. If you could do it a little better, it'd be better, but I could live with that. How's he doing? Stable? All right, Jordan, any way to make that, I guess that's, if that's the best you can do, I can live with that. I can live with that if I have to. Just try that. Shot? No, go back. Shot? So I need to go more medial. A lot of scar tissue here. Shot? All right, that's looking pretty good right there. Wait, hold on. The cap is coming out. Is that on right? Yeah, it is. Shot? I'm right on the transverse process. I'm in like the perfect spot. Do you agree? Yeah, that's the absolute perfect spot right there. You can see the superior facet. Show the superior facet. Yes. And then the lateral wall right there is where, right where I am is where it meets the transverse process. That is the perfect spot. Where do we go? Do you see it? No. Shot. 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 Jeez, this keeps forcing me laterally. It's a lot of scar tissue here. I'm gonna have to try to get through it. So what's happening is this prior surgery shot is all the scar tissue from that prior surgery is pushing my probe shot to away from where I want to be. Shot. Basically, that's better. It's kind of heading right where we need to be there. That's where I feel the bone. Too low. Shot. Makes no sense. It looks good on the x-ray, but I think right there, huh? Let me just feel. For those of you wondering, this is not just a visual thing, it's a feeling thing. And I don't feel like that's right. I think we're above the TP. That feels like the metal of the screw, or of the facet. Sorry, Sean? Everything okay, Luis? Sean? That feels better. I feel the TP. Let's see where we are right here. Shot. All right, that's not bad. Not bad at all. You really have to feel the bone of the transverse process below your tip on your device. Otherwise, the x-rays can be a little bit deceiving. So you have to use the x-ray, but you have to use your brain as well. And you have to think, where am I? And it's really important to always feel bone below your tip. I can't emphasize it enough. The bone is the most important thing as a guide for spine surgery. The bones of the spine. Shot? Yeah, that feels really good because I'm feeling the TP right there, the transverse process. I'm feeling the bones, and I really feel that that's the right spot. All right, let's hope that did it. One more to go. Same thing on this side. We're going to aim for that little valley. For some reason, a lot of arthritis. Shot. Too medial. I need to be more lateral. Wow. Shot. Yeah, it's the iliac crest. Shot. A lot of scar tissue. Shot. A little bit more medial than I really want to be, but I'm being forced down this path by bone and scar from the prior surgery. Shot. Too low. It's better, but still too low. That feels pretty darn good there. I think we're close. I'd like to be a little closer. But like I said, there's like a channel of bone and scar tissue. What do you think, guys? Pretty good, huh? Yeah. I just feel so much scar tissue. And it's pushing me down. Pushing me medially and down. Alright, let's try this. That's about as close as you can get. Right there is really good. Go ahead. So this will be our last one in the lumbar. And then we're going to go to the thoracic spine. Shot. Shot. Not an easy one. You see something is deflecting the blade there.